Dabrafenib and trametinib got an FDA license because in the setting of a BRAF V600E mutation, it has something like a 66% response rate and a PFS of about 9 months. So it's a classic targetable oncogene. And that's good enough that that's something that you would prioritize over chemotherapy. So that's why it's listed as something you would do first. And it doesn't matter what the PD-L1 status, doesn't matter what else is going on. If you knew that information, you'd go for a BRAF-MEK combination up front. BRAF inhibitor monotherapy is not something you would normally consider. The response rate is about half that. In fact, it's actually more toxic than the combination. That feedback loop that you interact with the MEK inhibitor, when you use the MEK inhibitor together with the BRAF inhibitor, in many people it actually reduces the side effects, certainly reduces some of the cutaneous side effects where people get appearing squamous cancers, and that's much less with the combination. It's not the easiest combination to take, though. There are side effects. The common things are pyrexias and rigors. And that's quite a shock to a patient because they can suddenly feel like they have the worst flu they've ever had. If that happens, there are very clear instructions in the patient information sheet. You'd probably hold the drug. You can give prophylactic antipyretics like Tylenol. Sometimes you need to give little short courses of steroids. Sometimes we'll even use Demerol. And you find a kind of a balance that works for that patient. And there are very few of my patients who can sort of stay on it completely uninterrupted. It's unclear why people will still suddenly have a day when they just have rigors and you have to do something about it. Non-V600E mutations in BRAF, I think, are very much a work in progress. Some of them clearly don't respond to BRAF inhibitors. Some of them maybe might respond to MEK inhibitors, but I think most of them, they're not targetable as yet. There's certainly no approved agents. I think they're going down the chemotherapy or chemoimmunotherapy approach. Something like half the patients with a BRAF mutation are actually smokers. So it's not your classic, never smoking female Asian that we learned about with EGFR mutation. So first of all, that means you should be testing people for it, even if they don't fit your classic, they've got a driver oncogene subset. But it also means that maybe even though other driver oncogenes don't respond quite so well to immunotherapy, this might be a group where adding in immunotherapy to chemotherapy certainly makes a lot of sense, or if you didn't use it, you can even use it as monotherapy. If I find someone with a BRAF V600E, then I'm going to try the standard full dose dabrafenib, trametinib, and then I'll go down on the dose as and when they don't tolerate it. If they don't have a V600E, then I'm probably going to treat them as if they don't have an actionable driver oncogene. They're going to get chemotherapy or chemoimmunotherapy, depending on whether they have any contraindications to any of those elements. I think if you knew a patient had a V600E mutation, and even if they had high PD-L1, you'd still try and prioritize the TKI approach. I mean, it has nearly a 70% response rate. Even tumor proportion score of 50% is running about a 48% response rate with immunotherapy, maybe about 60% with chemoimmunotherapy plus the side effects of chemotherapy. So I think it's a bit of a no-brainer. You try and prioritize the targeted therapy, and indeed that's what most of the guidelines will actually suggest. You would prioritize targeting that V600E and keep everything else in reserve. Sometimes somebody might ask, well, can you combine together the TKIs with immunotherapy or chemoimmunotherapy? And the answer is no. In general, TKIs combine very poorly together with immunotherapy. Conceivably, you could combine them together with chemotherapy alone, but I don't think that's what we're currently doing as a first-line option. So if you look at the patient information sheet for the dabrafenib trametinib combination, you can see that the number one side effect of these rigors and pyrexias, and that's, you give antipyreticals, you give steroids, you give dose holding and dose reduction, and then there's a list of kind of rarer side effects. You can get fatigue, there's a marginally increased risk of hemorrhaging, there's a very low risk of cardiomyopathy, you can get some eye abnormalities. I mean, these are all kind of single-figure percentages. But I mean, if you're a good clinician, if somebody comes in and says, I'm getting blurry vision, you send them to see, the ophthalmologist to figure that out. If they're starting to say, I'm becoming short of breath, and you rule out a respiratory cause, think about a cardiac cause. If they start, hemorrhaging, that's a bit of a no-brainer. Biggest side effect that I think affects the acceptability of this regime is the rigors and the pyrexia. I mean, I've certainly had some patients, especially more elderly patients, who've said, I can't put up with this. And what you have to do is you have to reassure them. You say, just hold the drug, we'll let it settle, and then you work on what regime works for them, be it a lower dose, be it regular low doses of steroids, Tylenol, etc. If this is the first time you've ever started a patient on dabrafenib and trametinib, make sure you've at least read the patient's information sheet so that you know how to manage the side effects. But I think you have to go in and you have to say to the patient, this may or may not be tolerable at the initial starting dose and regime that we're going to start you on. So let's just take it cautiously. Put them on it, bring them back fairly soon, reassure them that if it's bad, you can play around with the dose and the schedule and supportive medication.